Good evening. I think we're live. I think I got a little note then. Good evening and welcome to the first of what we hope will be many live Q&As for PANDAS UK for the closed Facebook site. Bear with us. This is the first time we've done this. I've spoken with Vicky and Dan at the charity for quite a while now, and we were coming up with ideas of things we could do that were positive, that would move things forward, and this was one of the ideas that we had. But there may be some technical difficulties, so we've got a lot of questions to get through, and we've got some amazing guests tonight. Our two clinicians who have both worked in the health service, and we know that can be personally and professionally challenging at the best of times. So, well, you have our huge respect and gratitude for using your skills to advance the care and treatment in PANDAS particularly. I'm just first going to say, quick disclaimer, our experts tonight are going to be giving general advice and suggestions and experience. We can't answer specific individual cases, mainly also because we want to benefit as many people as possible. So we're going to try and keep this broad. We've got a lot of questions. We may not get through them all, but don't worry, because we're recording this and our moderators are going to go through things later as well and post links and useful advice and suggestions further to what goes on. So moving forwards, let's just take a couple of seconds to introduce ourselves. I'm Jo Joyner. I'm your new ambassador for PANDAS UK. I've had PANDAS in our family for about 9 years. So when I found the charity, a huge admiration to everybody that started it. I wished it was around in the early days of our experiences. And it was very important to me that I did everything I could to help the charity. So I approached charity myself. So I'm really pleased to be on board as ambassador. And that's my links to PANDAS. Professor Gupta here, who is a consultant paediatrician with Neurologist from Birmingham Children's Hospital. Would you like to just tell us a little bit about your involvement and your interest in PANDAS?
Yeah, thank you very much for the kind introduction, Jo. And thank you, PANDAS UK. Particularly Vicky and Dan for inviting me to speak here tonight. So I'm a paediatric neurology consultant at Birmingham Children's Hospital, and I first became interested in PANDAS probably around 13 years ago when I was introduced to my first patient with this condition. And she was diagnosed having PANDAS by a child and adolescent psychiatrist that I was working with at the time. And ultimately we went down the treatment route, and she responded very well to the treatment. And that sort of opened my eyes to the condition, whatever you wish to call it. And subsequently I have basically developed that interest. And when PANDAS UK was formed, my interest in this condition actually increased exponentially, really. And that was because of the work that PANDAS has been doing in highlighting these conditions, not just to you all, but also to health professionals as well. So excellent work.
Thank you. And thank you so much for joining us tonight. And we also have Diane Palmer, who is the Associate Director of Nursing for Norfolk and Suffolk NHS Trust, and is also PANDAS new trustee. Welcome.
Thank you, and thanks, Jo. So my interest in PANS and PANDAS really has been over many years now, as I have a family member diagnosed with PANDAS, and I wasn't aware of the charity until about a year or so ago, and I saw something on social media, and I realised that there was still some of these issues and this alleged controversy around PANS and PANDAS, and I thought I need to reach out to the charity and see what I can do to help. And I'm in a position in my organisation and with the colleagues that I have across the UK where I can now help, and so I want to. So I'm delighted to be a trustee. I feel, very fortunate to be in a position to be able to help, and I will do everything I can to make sure that children and families get the care and treatment that they need.
Well, welcome, Diane, and we really thank you and appreciate all that you are doing. So shall we start with our first question? We've got some questions here that were already on the Facebook site, and we're going to have some more coming in on the live feed, so bear with us. Number one, how do you describe PANS or PANDAS to someone for the first time? Diane?
So when I'm talking about PANS and PANDAS, what I say to people is that it's an immune-mediated disorder. which triggers a whole range of neuropsychiatric symptoms. So I say, you know, an infection of some kind, you know, in pandas it would be strep, but in PANS obviously it can be a whole range of things. And I say this causes a sudden onset of neuropsychiatric symptoms that are broad in their range of, you know, OCD, tics, etc., but also that there are physical symptoms as well that people need to look out for example, you know, urinary frequency and things like that. So but I certainly don't describe it as controversial, is what I will say.
Yeah, no, I'm very careful not to do that as well. I think we need to take that straight out of it. Thank you. Number 2, what difference should people expect between PANS and PANDAS in the first presentation? Professor Gupta, is there a difference between the presentation initially of the two?
In the cohort of patients that I've seen, I think there's very limited difference, if any, between the two conditions. I think the presentations are very similar, whether it be PANS due to any infective type agent or whether it's PANDAS specifically due to streptococcal. Obviously, the two main symptoms of these conditions are the OCD and also restricted eating, but then there can be a host of other signs and symptoms that go along with these. So I personally don't feel that there is much of a difference between the two presentations. What I have found over time is that actually the presentations can be quite variable from patient to patient. Obviously the OCD symptoms plus or minus the eating issues are there, but the other symptoms are very variable from patient to patient.
And do you think this condition is caused by infection or inflammation or autoimmunity, or is it actually a sequence of the three?
So I think Diane's already alluded to that. I think it's a sequence of all three. The only thing that I would add to Diane's answer is I do tell my patients that you know, the pathomechanism is still not fully understood or has been fully proven. But the hypothesis is that you have an infection trigger of some description that causes your immune system to react, and then the immune system basically shows the antibodies that formed show cross-reactivity and basically start to attack the cells in your brain, and that in turn causes inflammation, which then causes the neuropsychiatric symptoms.
We've got a question that's come in from the live. How do we explain this condition to a family or friend, especially if a diagnosis is woolly, and who may simply not understand the debilitating nature of this condition? Yeah, so and they may not understand, and they may wonder why you haven't got a full diagnosis. What can they say to their friends and family who might not understand? Diane, do you have any advice for that?
Well, I guess, you know, it's how people understand these conditions, because the symptoms, people will say OCD, people will say ADHD, people will say, you know, eating restrictions.
And there's often masking, isn't there? So, you know, you can say it to a friend and they can go, well, they look fine to me.
Well, that's definitely one thing. And others will say, oh, this, you know, it's a fad. Everybody's got these different conditions. And what I would say is, this is a condition where a child's had an infection and for whatever reason, their own unique body hasn't been able to either get rid of that infection, so it's still harbouring some sort of infection that's making them unwell, or they have kind of got rid of the infection, but that sort of antibody response is still lingering and it's causing inflammation and it's affecting, you know, the brain. It's a, you know, it's an inflammation of the brain. And actually, if people think of it in a more physical sense, people seem to be less judgmental, and that shouldn't be the case, because actually mental health and physical health should be valued equally. But quite often, if friends and families think there's a physical cause, they actually seem to be more sympathetic to that. But what they then say to you is, well, how are you going to treat that? And what's going to happen in response to that as well? So quite often these conditions are viewed from a behaviour perspective. People talk about what's wrong with the child. What are the symptoms? What's wrong with them? There's a behavioural element. And actually, I don't see it as behaviour. I see it as actions. What do you visibly see from that child? And so I would just say, if you're telling a family member or friend, I would just say, you know, my child, my relative, whoever it is you're talking about, they've had an infection and their body hasn't responded very well to it. And as such, they've developed some symptoms that look a lot like other mental health conditions, but they're caused by a different, you know, they have a different cause.
That's good. That's good. We've got a question here. Why do some children suffer with PANDAS following a strep infection and others do not? I mean, that kind of relates to a question we've got later as well, where we're wondering whether there is a hereditary element, because there often is with autoimmune conditions, isn't there? And certainly since it's happened in our family, I've seen other people in the family and thought, I think you probably had it when you were a kid, way back when, you know? Professor Gupta?
I mean, I think that's an excellent question. I think basically with regards to PANS and PANDAS, there's probably multifactorial cause. So I think there probably is a genetic component which we've not fully understood as yet. And there may be other factors like sort of the dose of infection per se.
Right.
And these things together then cause you to have this reaction. And I think obviously if you don't have those factors, all those factors involved, then you don't go on to develop the neuropsychiatric symptoms. So it's probably a multifactorial onset, the infection, but possibly also genetic component. I think with time, we will actually find biomarkers which make individuals more prone to developing such symptoms. It's just a matter of time. We just need to make sure we do some proper research, multi-center, international research, and I think we will get there in the end.
Yeah, I agree. When you see a patient, Dr. Gupta, what are you trying to rule out as well as confirm to get your version of it? I mean, we don't have a full version of diagnosis, and we don't, you know, this is another thing that we're all reaching for, isn't it, and working towards. But when you're looking at a case, are there certain things that you'd also need to rule out as well? We know some of the common symptoms, but...
Yes, I mean, the history is the key component when diagnosing PANS and PANDAS. But we also have to recognize that it is a diagnosis of exclusion, because at the moment you can't sort of do a test which proves that this is a diagnosis. So what you're trying to do is, from the history and then by a process of elimination, ruling out other conditions, sort of thinking whether the history is in keeping with PANS, PANDAS. So there are a number of other conditions where you can present with similar symptoms. So you can have OCD on its own, for instance, or you can have tics on its own, etc. And those probably have a somewhat different pathomechanism to why they develop. So those types of things. Movement disorders can also present with other conditions, and they may be genetic conditions or metabolic conditions. We know that other conditions can present with neuropsychiatric syndrome. So there's a copper metabolism problem called Wilson's disease, for instance. And we know that other sort of autoimmune type reactions, so Lyme's disease, for instance, can also present with similar conditions. So there's a number of conditions which can have a similar presentation. So I think it's just important to sort of have that, look at the history carefully, also take into account family history, but also do a physical examination to see if there are any features that might suggest another diagnosis. And then obviously tailoring investigations for each individual child to try and rule out those conditions if need be.
Is there something distinct which might indicate encephalitis? This is one of the questions, and I don't know whether it means PANS or whether it means the difference between encephalitis, I suppose, and PANS. Is there something that's distinct between the two?
So is that to me, Jo?
Yeah.
Yeah, so it is very difficult to say, because I think if you're looking at the definition of encephalitis, you know, the presumed pathomechanism for PANS, PANDAS would still fit into an encephalitic type illness, because encephalitis just basically means inflammation of the brain. But we know that other typical encephalitis, whether it be due to a viral infection, for instance, often present with impaired conscious level, etc., which is not often there with PANS, PANDAS.
Yeah.
So clinically, I tend to sort of feel that encephalitis is much more severe with an encephalopathy with reduced conscious level or impaired consciousness, whereas with PANS, PANDAS, you get a change in behavior, but the conscious level is not usually impaired. And I suppose you can then do investigations, and if you're going to be doing analysis of the CSF, the cerebrospinal fluid, the fluid that circulates in and around the brain and the spine, with the traditional encephalitides, you would probably get evidence of some inflammation, whereas with PANS, PANDAS, you often don't get that typical evidence of inflammation around the brain. And similarly with imaging, in some severe cases of encephalitis, you will find changes on the MRI scan, whereas with PANS, PANDAS, you usually don't, and that's with the routine imaging of MRI scans. And similarly, if you do an EEG with some of the more severe encephalitises, you will get EEG changes in keeping with an encephalopathy, whereas usually with PANDAS, again, you don't. So I think from a diagnostic point of view, a definition point of view, sorry, I should say, PANDAS is an encephalitic type illness. But I think when you're talking to doctors and health professionals, when they think about encephalitis, they tend to think of a more severe presentation with impaired conscious level.
Yeah, I think that's a really good note about the impaired conscious level, because we had another question in from the live, which says, can PANDAS be described as a form of autoimmune encephalitis, as people seem to understand that, which I know for myself, people do seem to understand that a bit better than the you know, talking them through all the various other symptoms, but you're right, there isn't that impairment that you have. So maybe when you're talking to professionals, it's not a great idea, but maybe when you're with your friends, it might be a better, gentler way of sort of explaining to people. Back to the question we had earlier.
No, could I just pick up on the question you asked, which is what else are you ruling out? You know, what are you trying to rule out? And so I suppose the other thing is that ruling something else out doesn't mean that the child doesn't have PANDAS and PANDAS. So, for example, a child could have ADHD because they have ADHD, and they would have had that regardless of any infection triggered problems. And then they also happened to have developed at a later point PANS or PANDAS. And so there can be often this thing where people say, well, it can't be that, because if they've got that condition, then it can't be something else. But obviously these conditions can coexist and often do. So it's not unusual to see a child with ADHD, with OCD, with Tourette's, with all these different conditions. And so I think it's about saying, even if a child has another diagnosis, it doesn't mean they don't also have PANS and PANDAS. And the other thing is, of course, if they have a diagnosis of PANS and PANDAS, we don't want to have any sort of diagnostic overshadowing where we're saying everything's about their PANS and PANDAS, because we might miss something else as well. So it's not that somebody can just have one diagnosis, they may have more than one.
Yeah,
that's a really good point. It's a really good point, and it answered one of our questions already as well. But so we touched on this, but do you think, Diane, that PANDAS can run in families from your experience?
Certainly, you know, from my experience, I would say yes, you know, and I guess going back to that genetic component, I have to be careful what I say, because I'm not a genetic scientist in any way, shape or form. But I guess my experience is, if you look at some of these conditions, I think there is a genetic predisposition. And I think that's why we see in these children, when you ask the question, why does one child get PANDAS when they've had a strep infection, another child doesn't? I think there's this underlying genetic vulnerability that somehow gets activated. And so it makes sense to me that if that is a genetic component that becomes activated as a result of infection and autoimmune issues, that it would run in families. I mean, I'll ask for Raj to add to that, but I would certainly say yes.
Yeah, I mean, I think there is a genetic component, and a number of families that I look after, you know, there's more than one child with the condition. But I think it's also important to recognize that living with somebody in the family who has PANDAS is extremely stressful for the whole family, including other siblings. And ultimately, you have to, when another sibling presents with unusual symptoms, they need to be assessed in their own right. So I don't think you should basically just assume because there's another family member with PANDAS, this must also be PANDAS, you know, because it may actually be in response to the stresses that they're having, living with somebody in the family with severe neuropsychiatric issues from PANDAS. It may be learnt behavior, it may be attention-seeking behavior, etc. So I think it's just important that if there is another child presenting with symptoms, that they're assessed in their own right to see whether we feel that the diagnosis is still in keeping with PANDAS for them.
That's a really good point. And it also touched on another question that we had in where someone said, parents and families going through this can suffer from stress and anxiety, and there's a huge amount of emotional and psychological adjustment when dealing with these conditions. What can these people do to help with their own well-being? I mean, that's something that comes up on our Facebook site a lot, doesn't it? That, you know, it's exhausting, because as parents you take on the pain of any child that you're with, don't you? And so it's hard. Just the practicalities of everyday life can become very difficult when you've got a child with, you know, crippled with anxiety or OCD, but also just the emotional content is huge. Diane, do you have any tips or advice for this?
Yeah, well, look, first of all, I'd say be kind to yourself, because actually we're often our own greatest enemy. And, you know, managing the thoughts in our own head is really important. I mean, reaching out, being part of a support group like Pans and Pandas UK, obviously this is an invaluable charity, and the support that the parents have for each other, that shared lived experience and understanding, you know, is invaluable. However, if people do reach a point where they think, actually, this is really impacting on my own mental health, it's about being able to come forward. And there are services, certainly, you know, nationally in England, of course, we've got the IAP services, that's the Improving Access to Psychological Therapies, which everybody can just self-refer to. You know, you can go and speak to your GP and get support through that mechanism as well. And of course, there's lots of guided self-help on the internet now in terms of mental health support as well. So charities like Mind as well will have lots of information on their website. So I think it's about, you know, being kind to yourself, being compassionate to yourself. You will have other families, you know, friends that unfortunately at times will make judgments. People can sometimes be very unkind. You might be experiencing difficulty with relationships with teachers or friends or other people who don't understand your predicament. But sometimes it's also being kind to them and understanding they don't have the insight that you've got. They're not living this experience. And sometimes, unfortunately, seeing is believing. And if they haven't lived your experience, you know, they really can't walk in your shoes. So being kind, being compassionate to yourself, a bit of self-help if you can, support groups, but also if it does reach a threshold where you need to get support, don't be scared to go and see your GP or reach out to your local mental health service.
Thank you. Professor Gupta, I've got a question here. I mean, we've all said that we've not been involved for a huge length of time with PANS Pandas, but one of the questions here, do you have experience of children growing out of PP? Are we being too ambitious that this may be behind us one day?
So again, my experience of children who have now become young adults is that the symptoms do seem to settle down to some extent. It may be that these young people learn coping strategies with time, which they never had initially. So my view is generally that things do seem to improve as you get older, but I think what we also need to recognize that there will be some cases where they don't improve with time, and also there are cases which have been reported manifesting in adults as well. So it's not purely a pediatric condition, even though that's what the name suggests. But in my experience, things do seem to improve with time as you get older.
Diane, do you have any thoughts on that?
All I would say is I hate to be sort of doing. I haven't seen anybody who I would say has been cured as such. What I would say is that my experience is that symptoms can certainly improve over a period of time, particularly things like the tics. That we know generally in people who have tics that they generally peak during adolescence and can improve afterwards. So it also depends on what treatment I think somebody's had. And if we get better, I think we can be optimistic that if we get better at identifying this early, offering the appropriate treatment early on, and the less damage that's done, I think hopefully we will see improvements and we will see people cured. Or at least managing these conditions in a more proactive way. So if we see signs of infection, if we see somebody is kind of, they've got a recurrence of their tics and so forth, and we can proactively treat it without having to have a battle to get the appropriate medication, I think we've got cause to be optimistic that things will improve. We probably need to see a long-term study to truly understand what happens as people reach adulthood. And the name, you know, Paediatric, you know, it kind of makes people think someone hits 18 and it all goes away. But I think Raj picked up on a very good point, which is children adapt and they learn to cope and live with their symptoms, and people start to really accept them for who they are, even if they have certain behaviour, certain ways about them that is a bit different, people actually, by that point, they've worked out who their friends are, they've worked out who they can spend time with and be accepted by. And I think some of the pressures that they experience in the school environment have gone as they reach adulthood. And so I guess in a way it might mask that they've still got this condition, but they cope with it better as they get older. I guess that might be happening.
Yeah, and I certainly think as well, if we're talking about this as an autoimmune issue, that the more robust they become and the stronger, you know, they are as they grow, you know, the more we can hope that they can fight that off. And I think, like you say, with earlier treatment, those pathways that are being opened up, certainly in terms of OCD and sequences and things like that, you know, the sooner we can head them off with treatment, that's got to be better, hasn't it?
And so, children are in a breeding ground in school for infection. And so when children are small, you kind of expect they're going to get a lot of infections. They're going to get chickenpox, they're going to get strep, they're going to get different viruses, because this is what happens in school. But obviously, once they get older, their immune system does improve and it does fight off infection. They're less likely to have the kind of flares that we see in the earlier years.
We've a question that's just come in here. What's the value of CBT and mental health treatments if PANDAS is a physical illness? From our experience in my family, at the height of a flare, it would be impossible to implement a huge amount of CBT, although we all tried. But then once out of a flare, it seemed like a really good opportunity to enforce things with, you know, sort of a toolkit for should we get it to this place again. And that seemed to be a better time to do it, because it does feel very physical when it's in its peak, doesn't it? What are your thoughts on that, Professor Gupta?
So I fully agree with you. I think ultimately the approach has to be multidisciplinary. So I don't think you can just basically use physical treatments, that you do need to basically have the mental health services involved to provide that support around the child to help them develop strategies. Also liaise with the school so that other professionals that are involved with that child know how to manage that child most appropriately. Provide them with that pastoral support that they need, time out that they need at times. Also recognize that some days will be worse than other days, and basically make sure that the child is supported throughout. So I think it's important that that multidisciplinary approach is used, but unfortunately, in the majority of the cases that we see, that multidisciplinary approach is not available as yet. But you know, I would hope that right from day one, where you're basically making a diagnosis or are looking potentially where there's other causes for the presentation, that it is a multidisciplinary approach. So I'd love to see, you know, neurologists and community pediatricians and GPs working alongside the mental health team, basically working towards the same goal of improving the outlook and the quality of life for these children and their family members.
So onto it. Here's the word that we didn't want to use, the controversial word, antibiotics. Why is this?
Sorry, can I just before you ask that, can I just go back to the CBT?
Oh, sorry, yeah.
It's okay, sorry. So because I have quite a strong view on this. So obviously my background, people will know I'm a nurse because that's in my job title, but I'm also a CBT therapist and a psychotherapist.
Oh, right.
And so the important thing around the CBT is the expectation of what that will do. And so I think the concern is, we talked about the impression that friends and family will have if you've got a child with PANDAS. If your child is offered CBT, what people will think is your child has a mental health condition and some CBT is going to treat it. So there's something about perception of what the treatment is and what it's for. So I think we need to be clear. This is a physical condition. It manifests neuropsychiatrically, but because you've been struggling with these symptoms, it's likely that it's had a secondary impact on your mental health, i.e. you may have felt isolated, you may have felt confused, you may have felt ostracized at school, you may have felt picked on by your teachers, you may have felt rejected in your peer group. So CBT has a role in everybody. I love CBT and I use it in my own life. I think it's great. But it has a role in supporting children and supporting parents. And in fact, systemic family therapy can also be really useful. But it's really important that what we say is this treatment, this mental health intervention, is treating the fallout of having PANS and PANDAS. It's not treating PANS and PANDAS, because PANS and PANDAS is an immune mediated disorder. It's not a psychiatric primary disorder. And so, yes, CBT is positive, but it shouldn't be one or the other, i.e. we won't give you antibiotics or antihistamines, we're going to just give you CBT, because that will make the child feel like a failure. Because if the underlying infection, inflammation is not treated and they're just given CBT and they don't get better as a result of that, the child will put the onus on them and will feel even worse. So you said the right thing, Jo. Timing is everything. Treat the physical stuff first and then look at what is the fallout from that and what help can we give. So I wouldn't ever say reject mental health support. There's a role for CAMHS, there's a role for mental health support, but it needs to be done in the right way with the right messaging.
That's really great, Diane. Thank you. So our question was, antibiotics, why are they so controversial? What is or isn't safe? And what does a family do if they can't get access to antibiotics? That's probably one for you, Professor Gupta.
Yes, I mean, I think we have to recognize that all medications have potential side effects. So you shouldn't be dishing out medications unless you know why you're dishing them out, okay, or why you're prescribing them. Now, I think the issue is that with antibiotics, doctors are generally now being asked not to prescribe antibiotics too often unless you're sure that an antibiotic is needed. That is because most common infective type illnesses are viral and antibiotics don't work for them traditionally. Also, we have to be careful about the increasing resistance to antibiotics that's developing, probably due to overuse of antibiotics, and that's more so in some countries compared to others. Also, we have to recognize that antibiotics can potentially cause problems. So, for instance, often having gastrointestinal symptoms with course of antibiotics, sometimes having long courses or repeated course of antibiotics increases your risk of developing other bacterial infections, and which can produce toxins which can be quite injurious to your health as well. So I think in answer to your question, one is that doctors are generally being taught not to prescribe antibiotics. Also, with PANS, PANDAS, there may not actually be an acute infection there and then. It's basically the fallout of having had an infection at some point. And the third thing is the reason why we think antibiotics work in these conditions is not necessarily to fight bacterial infections at the time. It's just that we think that these antibiotics also probably have an anti-inflammatory type effect, which proves helpful in these conditions. And also about antibiotics having an anti-inflammatory effect, that is unfortunately still a bit controversial in the sense that I don't think many health professionals necessarily appreciate that. And it's not been proven as yet that antibiotics generally have an anti-inflammatory, or not accepted, I should say, widely, that antibiotics have an anti-inflammatory effect.
Is that the same effect that when we hear people saying that they have an autoimmune regulation, they sort of regulate, that regulatory effect, is that an anti-inflammatory effect? Is that the same unproven kind of?
That's right. I mean, generally people are I think it's becoming more accepted that antibiotics don't just fight bacteria, but also do modulate your inflammatory response or your immune response. And therefore, we think that this is why it works, why they work well with PANS, PANDAS. Specifically PANS, because PANS may be due to a viral trigger, for instance, whereas PANDAS we're saying streptococcal. So you can sort of think that antibiotics might help with streptococcal infections because obviously there's a bacteria involved there. But why do they work with PANS? You know, they shouldn't do if it's purely because they're fighting bacteria. And that is basically the anti-inflammatory or the immune modulating type effect that we think the antibiotics have.
What advice would you suggest for speaking with your doctor and getting their attention? So Diane, have you got any suggestions for this? How do we get clinicians to listen to our concerns? If you're first approaching your GP with your concerns.
Well, I would say in any GP practice now, you know, you don't always have to see your named GP. So find a GP that you feel comfortable with. If you've got an experience of a few GPs in your practice, find the one that you feel particularly comfortable with. and try and keep with the same GP if possible, if you're trying to address these concerns, because it can be very difficult. What you don't want is varying professional opinions, and you go to one doctor and they say, yes, I'll give you some antibiotics, then you go back a couple of weeks later to try and have the same conversation, you end up with another doctor. So try, the consistency. So find the right GP, be consistent. There is nothing wrong with educated patients. And I really hate this perception that patients shouldn't come forward with their own information. We've all gone to Google, whether we're clinicians or whether we're a lay person. We look, we're educated, we go and find this information. But go to credible sites and get credible information. And obviously PANDAS UK has got a wealth of information that you could print off or have on your phone and share with your GPs, because many of them won't be familiar with PANS and PANDAS. So if you can print something off that's, from a legitimate site like this and take that with you, that will go a long way. And, if you're concerned with the approach that your GP has with you, first of all, try and talk to your GP about what that concern is and the impact that that's having. But also remember, you have a right to ask for a different GP. You have a right to ask for a second opinion. And just also keep a note of your consultations as well, if you can, keeping a record of things. And I just also urge people to check for factual inaccuracy. So if you're saying something to your GP or any medical or clinical professional, ask for copies. I don't care. I'll ask for copies. If I go to the doctor for anything, I might say, can I have a copy of that letter? Because sometimes they get things wrong, not deliberately, but they might just document something that you haven't said in a particular way, so just making sure that everything that is written about you, your child, and what's happening is an accurate reflection of what you're telling them is going on at home as well. But building a good relationship with your GP is really crucial, because they play a really important part in getting support. And in an ideal world, we wouldn't be seeing children have to go to Raj and other specialists, because in an ideal world, there would be better education in primary care. And hopefully, as soon as a child had a sudden onset of this, they would be treated quickly, and hopefully it would be managed within primary care, and only those kind of more complex cases there it's really difficult would end up with Dr. Gupta.
Thank you. I've got a question here from the live, which I might have something to say about as well, actually. Things have settled down a lot for my daughter. The major symptoms she's left with is sleep problems. Could this still be related to having PANDAS? And I've had some experience of that, and I would suggest magnesium supplement for a start if you haven't tried it, because it definitely helped with our sleep. But also you can form these patterns for yourself, can't you? Sleep patterns already. So, it may be that that's the last thing to settle down now, because we're in a habit of it, and it's more about breaking the habit possibly. Have you got any thoughts on that, either of you?
Yes, I fully agree with you, Jo. I think it can take a while for sleep to improve in PANDAS. Even though there's no sort of active inflammation per se. And I think it's important to try sort of the usual techniques, a good sleep hygiene, making sure that there's no distractions overnight, making sure that there's a nice sort of calming routine before bedtime, and so on and so forth. And also maybe even trying some natural remedies, as you said, try magnesium supplements or anything like that. I don't think there's any harm in trying these things just to see that you can improve. And often, once you get into a good regime, a good nighttime routine, things do settle down over time. So I think I agree with you that poor sleep is probably a knock-on effect of having gone through what you've gone through, and not necessarily due to active PANDAS.
Do you have any thoughts on that, Diane?
I would just say, in my experience of the children, young people I've seen, that sort of ADHD type component to PANS and PANDAS, that hyperactivity, it's really commonplace for sleep patterns to be disrupted, for children to be up 1, 2, 3 o'clock in the morning, and you know, be quite sleep deprived. And it's a vicious cycle, because the more sleep deprived you are, the more sleep deprived you end up becoming, because you get into a very vicious cycle. So I just echo, you know, Raj's sort of sentiment, really, that good sleep hygiene, what people do. A lot of these young children will be on social media, they'll be on their phones, and that's one of the worst things for sleep deprivation, is the light that emanates off of technology stimulates the brain. And if you've already got issues around hyperactivity, that's just going to make that a whole lot worse. So turning technology off a good hour or so before you want to go to sleep is probably quite critical, and not drinking, you know, fizzy caffeinated drinks and things like that.
Yeah, and I know in cases that I've seen, the stress that you can put on it as a parent about this bedtime, because you feel like you've fixed all the other things and everything's going really well, but you can't be going to bed at 11 at night. But actually, the less you can, if you can withdraw that stress, if you can have if they're old enough to be able to say to them, listen, this is the last bit of the puzzle, and I know you're finding it hard to go to sleep, so let's make sure the lighting's right, let's make sure we've been off electronics, but I'm not going to shout at you to turn the lights off and go to sleep. I'm going to say, you sit here, maybe write your diary, do your bit of CBT, and in a calm environment. It's going to take time, but you will fall asleep eventually. And if you both feel like that, rather than you worrying about them not getting enough sleep, sometimes that's enough to take the edge off of it, and to make them feel like it's not another mission that they've got to do to go to sleep, and that it often happens a bit quicker.
And also bedrooms in younger children, thinking about what is a bedroom for, and if you really put that as a place to sleep and as a calming environment, if it's a place where you've got an Xbox and a PlayStation and an iPad and a whole load of toys and games, and it's a place that's a lot of fun to be kind of being in and doing that, that's going to be a lot more distracting. And actually, children generally who don't have televisions in their room and don't have all those kind of things, even keep them in the lounge or in a playroom or somewhere else, in the conservatory. Actually, children tend to sleep better if they associate going into their bedroom with actually going to bed.
So following on from Professor Gupta's comments about antibiotics, would antivirals be a good option if a child has PANDAS?
I don't routinely prescribe antivirals, but I know that some people do, and they seem to respond well to them. So I think it has to be very much based on on each individual child, particularly if they, for instance, are getting herpes on a regular basis or herpetic lesions around the mouth, etc., and that seems to be a trigger for them. Then yes, I think antivirals can be helpful in some cases.
Another question here is, my child doesn't have flares. He just changed overnight and has been the same ever since, but all the symptoms fit. Do you have to have flares if it's PANS or PANDAS? I mean, I suppose the question there is, that comes down to that fine line of whether somebody just has OCD, and at what point do you develop it? And if you're not, if there's no ebb and flow, does that mean that you have just got this one symptom, or
I think it's very difficult. As I mentioned right at the beginning, the presentation of PANDAS is extremely variable from patient to patient. So I think each individual child needs to be considered, and basically just sort of seeing, for instance, was there a trigger initially, an effective trigger initially when this happened? Has there been a flare right at the beginning, and things have sort of improved and just remained constant since then? So I would basically say that if you don't sort of get that ebb and flow, like we normally do expect with PANDAS, doesn't necessarily mean it isn't that. I think it's worth basically looking at and exploring further to see whether other features are in keeping with PANDAS.
So we're moving on to living with. Should people consider an anti-inflammatory diet or particular dietary supplements? I know that has helped my family members a great deal, actually. After antibiotics, we were actually set to do a prophylactic course, but we had a lot of sickness that came with the antibiotics, and we decided while we were waiting to see a naturopath and try a lot of other holistic things and dietary changes and supplements and things, and they made massive improvements. So I wonder what you both think about that. Diane, do you have any thoughts on that?
I've had several people contact me this week, actually, and a couple of nutritional specialists actually contacting me to discuss PANDAS and PANDAS. I definitely think looking at diet and looking at sort of vitamin deficiencies is really important, and looking about the kind of foods that a child is eating, and some foods are more inflammatory in nature, what you put in your body. So I think diet is really important, and we see children with these eating restrictions, so they might not have a very varied or appropriate diet in the first place. So my view is looking at the nutritional deficiencies and things like, you know, B12 deficiency. And I know I've had a couple of parents message me over the weekend about this, and it's really interesting because that does seem to keep cropping up over and over again. And of course, B12 is linked heavily with neurological difficulties when somebody is really depleted in B12. So to me, diet is very important. It's not the be all and end all, because it's not, you know, taking some multivitamins probably isn't going to cure the problems, but certainly addressing the diet, I think is you know, fundamental. And you know, I'll hand over to Raj to see what he thinks, but that B12 connection is probably one of the ones that I've seen in every case, actually.
So again, I do a lot of learning from my patients, and I know that a number of my patients have seen improvements with dietary changes and use of vitamins, etc. I think so. Obviously, I think they are important for a proportion of these patients, and they do help with a proportion of these patients. What I tell my patients, however, is not to try too many things simultaneously, because then it becomes very difficult to try and tease out what's actually working and what isn't, and what potentially might be making things worse. So, you know, I do sort of say that if you want to explore dietary exclusions or modifications to one's diet, that, you know, feel free to do so, but try and do one thing at a time. And what I don't like to see is when children are being excluded off everything, and you sort of think what's left. So I think basically if you've tried something and it's not helped, maybe reintroduce that and then try excluding something else, or try making another change, as opposed to just keep on taking things away.
Yes, life's hard enough, isn't it?
Yeah.
If you could, I mean, this is a good question for both of you, actually, and you may have very similar answers. If you could design the perfect treatment plan for the NHS to follow for PANS PANDAS, what would it be? So we were talking about that frontline defence. You know, if you could design the perfect pathway for when somebody arrives at their GP and says, this has happened overnight, or this is, you know, this has happened straight after this infection or this virus, what would your dream be for all of us, Diane?
So I think I started to allude to that earlier, which was, in an absolute dream world, a parent would take their child to the GP, and the GP would say, this sounds like it could be PANS or PANDAS, and I'm going to start a course of treatment so that we can, you know, look at this, and I'm going to run some tests, I'm going to do a strep test, I'm going to take some bloods, and, you know, offer a very quick intervention. And hopefully that would, you know, resolve the difficulties. If the child then needed an onward referral, perhaps the issues were still, you know, quite significant. In an ideal world, it wouldn't go down one route or the other. This is where I have a gripe of children are being referred into CAMS because, and I understand why doctors are doing this, because if I was a GP and a child presented with neuropsychiatric symptoms, it makes you think, CAMS. But the problem with that is that there are very long CAMS waiting lists. And by the time the child actually gets to be seen by CAMS, the inciting infection that may have triggered this is probably long gone, undetectable. It doesn't matter whether they test them at that point, and they probably won't, because most CAMS doctors generally don't do a whole range of sort of physical in-depth testing. It's more of a clinical screening and diagnosis. So that infection history is lost because it's historical, could have been 12 months before they had that. So from my point of view, even if they go purely down the physical route, that doesn't really help either, because it doesn't explore what might be going on from a mental health perspective for that child. How are they coping? How's the family coping? So my view is that primary care try to manage it as best as they can. And if it then steps up, it should be a multidisciplinary team approach with neurologists, immunologists, psychiatrists, psychologists, and nurses all working together to come up with what are the right tests we need to do, what is the right treatment plan, whether that's antibiotics, antivirals, antihistamines, anti-inflammatories, whatever that might be. And it could be some mental health medication as well if that is needed. And then that should be reviewed and managed as a whole MDT, rather than just one doctor having to hold responsibility for that. And quite often, as we know, they get singled out. Why are you treating it like this? If you have everybody involved. And the voice of the child and their families has to be paramount, in that this support should be co-produced as a family. So I would like to see support for family members as well. So we should be asking parents, and how are you? And what's going on for you at home? And what can we offer you, to make sure that family members and carers are also getting the support that they need? So in an ideal world, that's what I'd like to see.
That does sound like a dream. Professor Gupta?
Yeah, so my dream pathway is very similar to what Diane says. I mean, I suppose the most important thing is education and acceptance by health professionals that we've still got lots to learn and lots to understand. And just because we don't necessarily understand why or how doesn't mean that those types of conditions don't exist. So what I tell health professionals, or what I ask of health professionals, is, okay, maybe you don't feel that you have the understanding or the expertise to make a diagnosis of PANS, PANDAS, or even consider a diagnosis. But if that's the case, there should be somebody else, another health professional, that is willing to consider that, so make the referral. What's always concerning to me is the fights that parents have to go through to even get somebody to listen. And obviously, if you are anxious about your child who's changed suddenly, dramatically, overnight practically, and basically your life has changed as well as a result of that as a family, you do want to feel listened to, at least. So I think what I would hope is that health professionals keep an open mind, listen to these families. If they feel that they don't have the expertise or the understanding to make diagnosis or consider such a diagnosis, then refer on to somebody else. But what's often happening is that these parents feel as though they're not listened to and are turned away, and then they've got to try and find another avenue to try and get some help. And that basically then obviously has that basically in itself provokes even more anxiety for the family and the child.
Yeah, it never ceases to amaze me how many professionals or scientists, I mean, science never advanced, did it, without a hypothesis or without people being questioned, or in the past people were thinking somebody's mad with the idea that it was the doctor's tie that was passing the deadly bug around, and so I'm always amazed that it's hitting so many barriers for so many people in our Facebook group. It feels like, since our brush with it first time years and years ago, things should have come on further. And to be fair, actually, in the last couple of years, I think, thanks to PANDAS UK and all of your work, the two of you, and many other specialists, it is advancing a lot further in the last couple of years than it has in the last 10. But yes, good practice. Let's have a look. Diane, let's a little bit positive, because we're coming towards, have I got any more questions? I'll check for more questions. But in the meantime, could you tell us a little bit about what you have been doing, your project that you're piloting down in Norfolk and Suffolk?
Yeah, so, I have to manage expectations here. Things take time in the NHS. Now, I say that, but I've managed to set up 9 other services in 12 months. So I'm quite fast at doing these things, but I'm not a miracle worker. But I've started to sort of pull together CAMS colleagues and colleagues from the acute hospitals, so that the general hospitals and the mental health trust, at every level, so consultants, nurses, allied health professionals, so that's speech and language therapists, that's physios, it's dietitians, all sorts of different people, and have started to deliver training sessions to those and get them on board. And what started to happen as I had those conversations is people said, I've got a child like that I'm looking after, can I come and talk to you about that? So now there's several cases that had been brought to my attention, and I'm supporting those families. So I've been out, I've met with the children, I met with the parents, and I've kind of become the conduit between the GP, the CAMS consultant, CAMS nurse, and the generally the paediatric neurology department in our in our acute hospital. And so what I've been starting to do is kind of give advice and support and make sure that things are pulled together. And in an ideal world, we want to see that progress to a specific model of care. Now, there's a couple of things happening. So I thought, right, well, I'm just going to do this in Norfolk and Suffolk, and then we'll pilot this, and then we'll see if we can get this spread nationally. However, I realised a couple of weeks ago that we are going to have, and this is in the public domain, a new children's hospital in Cambridge, and it's going to be the first ever joint physical and mental health children's hospital in the country. So I've now reached out to the people who will be the directors of that hospital, and I've got a meeting lined up with them to see, does this specialist PANDAS clinic actually sit beautifully within that? So if we can manage it in primary care, great, we'll do that. We'll educate, we'll train loads of GPs, and I am in discussions with the Royal College of GPs at the moment about that. I'm also in discussions with Health Education England about training. But if it does go up to a sort of the next level up, that seems to be an ideal place to potentially do a pilot. But what I will still do is, in the meantime, before that hospital is kind of built and ready, is to continue to support children within NSFT. That's the trust that I work in with my colleagues. And we are in the process of pulling together funding bids to have a dedicated pilot. And the reason for doing that is not just to deliver a better service for those children, but to have a captive audience, because we can't do clinical trials and we can't do research and we can't get more evidence if we just have odd cases dotted around the country. We need to have a pool of children where we can get that consent and permission to be able to kind of do bloods and genetic testing and all sorts of different things. So that's what I'm working on at the moment, getting some funding to have a very specific model. But in the long term, there may be opportunities for these kind of specialist centres, hopefully one being in Cambridge. And obviously, you know, we've got amazing people like, you know, absolutely amazing Raj with the work he's doing. And we just need to make sure that across the country that we don't end up with the postcode lottery, that wherever a child lives, that they have access to one of these specialist centres to get that support.
It's incredible, Diane, and we're really grateful for everything that you're doing. It's very exciting and very positive. Raj, do you have any, you know, is that the future that you envisage as well?
I mean, that is the future, I think. And, you know, my hat's off to Diane for all the work that she's done and all she's been able to achieve in such a short time. I'll have to come to you for some tips, I think, about how you've managed all this. I mean, in addition is obviously about collaboration with other centres in the UK, but also abroad. Basically thinking about research, maybe setting up registries as well of these patients, so that we can actually learn from them. As I said, you know, since I've become quite heavily involved with patients with PANDAS, you know, I'm learning lots. And I think obviously that's what we all need to do as health professionals, learn from our patients. So yes, I think collaboration is the way forward as well. And that's not just in the UK, but also internationally.
Well, that just leaves me to say thank you so much to both of you for your expertise and your time and your continued support going forward. We are all indebted to you, and anything we can do to help, you need to let us know. Thank you for listening today and joining us on the live chat. We hope to do more. This is the first of many. As I said, the moderators will be posting this on their YouTube, and they'll be putting this up so that you can rewatch it. And if you've got any more comments, they'll be adding links and any useful things they think that we've discussed throughout. So yeah, let's all keep positive. And if anybody's got any ideas for any further chats, people they'd like to speak to, you know, other clinicians or anything else they'd like to do in chats, put them in the chat and we'll have a look. So thanks very much, guys.